So good morning and good evening, everyone. Today we have Professor Bhramar Mukherjee from the University of Michigan, who is very much well known for her work around statistics and biology, uh, more formally a biostatistician. And Professor Bhramar Mukherjee joins us from Kolkata today. Uh, Thankfully, we have her in our time zones. And we want to chat with her today on her work around the coronavirus situation, both in the US and India, her perspectives, given that she has recently traveled from US to India, and what she has seen both on the supply side response and policy response, and also as a citizen, what she's observing in terms of the goods and bads between these two countries in the way they have responded to the pandemic. So thank you very much, Professor Mukherjee. We appreciate your time for our podcast. Any opening words would be appreciated. And then off you go if you can start on your perspectives as a scientist and also as a citizen.
Thank you so much, Hirantun. I really appreciate this opportunity to have the opportunity to speak with your viewers. I think that I'll first start with a little bit of history. That at University of Michigan, we have been modeling the coronavirus pandemic in India since March. So our first paper came out in March on March 20th, which is one of the first models that appeared in a formal way in the literature. And the way we started this modeling was much more of an altruistic reason, not for an academic reason, but really a group of us, scientists of Indian origin in the United States mostly, worrying about our parents and our loved ones and worrying about India and what is going to unfold in India in the next 10 months.
Mm,
Though India has a much younger population, we were worried about the fragile healthcare system,
mm,
access to healthcare, as well as the comorbidities that reside in Indian population. So from there, from March to November in these last 10 months, I feel like our science has really learned a lot. Science has progressed at a wartime speed. And also, as citizens, we have learned how to manage and mitigate our personal risks. So I
mm,
think there is this macro science perspective that we see in our academic and scholarly work, and then my own, because nobody is devoid of this reality context. So, in my own personal life, how do I manage and mitigate these risks? So, this duality and the juxtaposition of science and realism has been quite inspiring and a learning lesson for myself. So, in United States, we have seen United States and India are obviously the two countries with the largest number of case counts. And so there are similarities, but mostly differences in terms of how the pandemic has exploded in the two countries, as well as the country's response to the pandemic.
yeah.
And there are, of course, some common themes as well. So what I have been noticing, one is the public response, right? So
Mm,
in United States, some of the non-pharmaceuticals public health interventions became highly political. And
right.
here I see a much more uniform messaging. Whether the public is adhering to it, that's a different story. But
Yeah.
from the government about wearing masks, about washing hands. So there is an uniform sort of messaging. And also testing. I feel like testing is much. I have gotten tested 3 times in India in the last 3 weeks, and it has been much easier than getting tested in Michigan. So there
Mm,
are pros and cons, and it's a very interesting situation that how a low resource setting with
mm,
such a burden of population and highly dense population
mm,
deals with this pandemic, and
mm,
how a highly resource setting with science and healthcare is battling it. And the outcome, I would say, has been much worse in US because
mm.
of several confluence of several factors. So we could start with that preface and then move on with our conversation, Chirantan.
Great point. And that brings me to think about how is it that we talk about India being a very heterogeneous country. Those of us who are working in health know of this recent Lancet paper, which talks about India being a nations within a nations. And yet, when calamity has struck, as you rightly said, there seems to be some harmonization in policy messaging that is happening both at the center level as well as the state level. Any thoughts as to how that has been accomplished? and what that means for the next 12 months, since we are 10 months down the pandemic. How we how what we learn from in terms of how we can behave better, normatively speaking, for developed nations by looking at, let's say, resource starved nations like India.
So, yeah, so our first paper on this nation versus state heterogeneity appeared on medRxiv about in May. It's about to come, it just got accepted and coming out in British Medical Journal. And we pointed out this heterogeneity, and the concept of a national peak is very
Hmm,
nebulous
hmm,
because you just see local regional peaks. And
hmm,
as you can see,
hmm,
Delhi is probably in its third peak and
hmm.
maybe second wave. When India is really a conglomeration of all of these different
Small nations,
economic
yeah.
bodies, all the nations within nations, and the policies have been heterogeneous because there is a state and center partnership in terms of managing health.
Hmm,
But what I see is that the central messaging, which is a long term coordinated strategy, and messaging that, first of all, a national lockdown sent the message that this is an important disease, right?
hmm,
So you cannot really, it's not a hoax,
hmm,
it's real. And the guidance is, even when I was in Delhi, there were announcements in the market that if you don't wear your mask, there will be a penalty, your shop may be shut down. And
hmm,
so these kinds of like payoffs and like incentives and warnings. I think cautionary notes are very important from a
hmm,
government perspective. I also think that it going forward, it would be very important to coordinate this type of public-private partnership, which has been a tremendous success for India in terms of scaling up testing and
hmm.
also distribute healthcare. So when in March the 21-day national lockdown happened, we
Yeah,
really did not have any capacity for testing. And
yeah,
our healthcare in terms of COVID stream and non-COVID streams, this was really not organized. So I think
right.
that the lockdown really helped us to think through and bolster that. And there came the all the labs which scaled up their testing capacities and the different forms of testing, full testing and rapid antigen testing, RT-PCR testing, and serological surveys. This has been a huge success. We do not have a national serological survey in the United States, and India has done that. And I'll definitely recommend doing that repeatedly and also keep like surveillance and clinical testing in mode. The biggest challenge is going to come in the next couple of months with respect to vaccine
Vaccines.
distribution, right?
Yeah.
So, how do we do that? And how do we prioritize risks? And maybe we do have a registry of frontline healthcare workers, but what about people with comorbidities?
Hmm,
What about people, older people? Where is that roster and the database? How are you going to track that down in order to create a vaccine roadmap? This
that,
is where the state and the central government partnership is going to be critical, along with healthcare and public health. Because
that,
how to do the messaging, how to vaccinate in interior parts of India, how do you track all of this map of vulnerabilities? Because you don't want the digital divide to creep in terms of accessibility to vaccines as well. So lots of collaboration will be needed towards that direction.
so I want to probe a little bit on the testing anecdote that you mentioned, because I feel from there we can also segue nicely into the vaccine discussion. So while yes, internationally benchmarked, it does seem like it has to be appreciated how India has either through procurement strategies internationally or through domestic entrepreneurship shown by labs and scientists have been able to scale up. I mean, we also now have this CRISPR test that has come out by these scientists being rolled out through the Apollo chain and the Tata Diagnostic Labs. But at the same time, every now and then you see discussions on how India is suppressing test numbers or purposefully moving tests from RT-PCR to antigen testing, right? Just I think yesterday, NDTV had an article that 3.4 million numbers are being underreported. And we know that in infectious diseases, like even in smallpox, there is a lead and lag of actual numbers versus the what's being reported while the disease is rolling out. Perhaps the reason for all of this is that how do I put this? So basically, I think there is at one end some confidence in terms of what the government is doing perhaps, and at the other end there is acceptance in some sense, right? So we are somewhat of a whatever we get, we feel fortunate about it. In fact, we are so used to not getting so many things that we feel fortunate with whatever we get. That's one. Second is, maybe our institutions are slightly more relaxed about approvals. The fact that you couldn't do national surveys around the US perhaps needs regulatory clearance. Those regulatory clearances perhaps are a little more tractable and manageable in India, is my sense of it. Which is why you see quick rollouts, quick entry of different technological versions of tests, or go and do all these seroprevalence tests across Telangana or Mumbai or Delhi or Ahmedabad, etc. Because so many approvals perhaps are not required either from whoever the relevant regulatory authorities are. And we know that in US to get all those stuff done, you have to go through multiple loops and sometimes things get lost. Any reactions to those two issues? One, the trust issue that let's say population may or may not have, which may have facilitated unintendedly a better show on the testing infrastructure. And the second is the role of regulations and institutions here. Should rich economies like, let's say, OECD economies be learned from being a little more flexible on institutions when pandemics strike? Any thoughts there?
So, a couple of thoughts. One, let me first talk about the underreporting issue.
Mm,
So, we have been reporting and that in our papers that there is an underreporting factor of about 1:20
mm,
in major metros, at least in India. And
mm-hmm,
so, the underreporting comes from two issues. One is people who are not getting tested at all, right?
mm-hmm, mm-hmm,
So, we know that there is a high degree of asymptomatic infections,
mm-hmm,
and the percentage of COVID infections in a place like Delhi or Maharashtra is around 98% of the infections are not being detected. So you can see that how small the tip of the iceberg that we are seeing right now.
yeah,
So that's one part. And then, given the people who are being tested, there's underreporting. And this underreporting is sort of dangerous because the RT-PCR test is also not very good in terms of false negative. It could have
mm,
15 to 20% false negative. The false positive rates for these tests are lower. And then when you come to rapid antigen tests, some of the tests in India has false negatives of around 40%, right? So it is as good
mm,
as, like, not tossing a coin. So, but what I'm saying is that you have to really understand when you think about the testing strategy that for the cost of one RT-PCR test, you can possibly do 10, let us say, rapid antigen tests. So if I actually repeat antigen tests,
and these are
or
probabilistic,
then
yeah.
you can actually increase the accuracy. So you have to think about that. And also, when we recommended the antigen test at the time, India did not have the capability of doing large scale RT-PCR testing because of expense and also prohibitive resources and structure. So the large scale rapid antigen test is more for surveillance,
Mm-hmm,
not for clinical diagnostic testing. So if
I
your
see.
symptoms really persist and you get a rapid antigen test, you should not be complacent with the false negative and go around and spreading the disease with your family and friends. If you have symptoms, you have to follow that with an RT-PCR because that's the gold standard clinical diagnostic testing. But when we are doing population-based, like, surveillance that I want to check, then repeated, like even the testing a person 3 times with rapid antigen test over a period of time can give you a good idea of community prevalence. So we should not get these two mixed up in terms of diagnosis versus surveillance or just keeping a tab on whether there is an outbreak or not. And
Okay.
so I think that that's something that we need to understand. And false negatives of these tests are particularly concerning because you have a false sense of assurance that you do not have the disease. So
Yeah,
maybe you are even more overzealous. So
yeah.
the basic mandate is that if you have any kind of symptoms, self-isolate. Regardless of the test, what the test says, then wait for a 2-3 day period. And employers and family members in society needs to support an individual towards
Mm-hmm,
that. It's hard for people and daily wage earners if there is a strong penalty. But
mm-hmm,
I'm seeing at even at our household level, There is a constant messaging. My mom is telling the household help that please, if you cough, please don't come to work because we are at risk. So I think these types of, so this social response is very different in India
Hmm.
than in the United States, right? So I wanted to decouple that testing strategy. So I think that this is very important to keep in mind. And then going forward, right? So there is a, if you, what is the expectation of the public from the government? You mentioned that our expectations are so low that whatever we get, we are happy. That's one strategy to be content. But I have to say that there is this all over the world. You are seeing this fatigue, this desensitization, this
Yeah.
rebellion against interventions and restricting people's life, question about freedom, question about happiness.
Hmm.
So I think we have to think about the other components of human life.
Hmm.
Coronavirus cases is only one metric. There are deaths and morbidities happening because of
In other.
people are not seeking care due to other diseases. Mental health, loneliness, solitude. So many parents are waiting alone because their kids and the family cannot visit them. So this is also taking a toll on our society.
And
And
missed chemotherapies and postponement of other medical interventions as well. Yeah.
yes, I work a lot with cancer patients. Even in Michigan, delay in care in cancer patients is going to have a huge effect on their survival. And we have to sort of convince the people that what are the risks? What are the relative risks for dying from coronavirus
Hmm.
or really having a recurrence of cancer that
Hmm.
may metastasize because you are not doing your regular checks. So,
Hmm.
so this communication is very important, and to view this problem in the coming months in a holistic way so that we can provide support from other causes
Hmm.
and we as a society are prepared to heal from this
Hmm.
pandemic.
Hmm.
Even with the vaccination, it has taken a mental, emotional, and health toll on an economic, of course, on on various sectors of the society. And so it seems like a philosophical thing to say, but we will need to heal at a very granular level in the coming years and coming months.
Very well said. Um, Anything about the institutional part? Maybe what the richer world can learn from being institutionally agile and responsive when
So yeah,
emergencies
so
strike.
I have learned quite a bit in the last 3 weeks. First of all, what I see is a great deal of mask adherence
Yeah.
in the working class people, the cab drivers.
Yes.
I did not expect it. The cab drivers, the household help, the street vendors on the shops. I think they are afraid that if they don't do it, they're not
Yeah.
going to get business and there will be another lockdown.
Yeah.
So I think this sense of seriousness was really striking to me when I first got in Delhi.
Very
And
true.
the second, so and that I did not see when I was in Michigan, that
Hmm.
people were at a grassroots level universally taking that so seriously. All the masks are not perfect, right? The wearing, covering of the
Right.
nose, that's not perfect. The
But they're trying.
behavior,
They're trying. Yeah.
they're trying. The behavior, the effort is important. Then if we think about like how the pandemic was managed in really slums and very highly densely populated areas, that's something to learn for the whole world. There is not universal random testing or universal mandatory testing, but the health workers door to door checking of symptoms,
Yeah.
fever, cough. Another thing which is very important is the centralized facilities, clean facilities for centralized isolation and quarantine, because most Indian households are
Yeah.
highly populated and densely populated. It's impossible to self isolate in your home. So to take that case outside to prevent cluster and neighborhood infection, that's something to learn. And again, I mentioned about testing already, that when you have home collection protocols, and even if you don't have insurance, you pay only like 1,500 to 2,000 rupees, which is 20 to $25. Whereas in US, out of pocket cost for an RT-PCR test ranges somewhere from 150 to
Hmm.
$300. Why is that? So you have to think about like what is the economy and the availability and the demand and supply doing? Something is not working. And of
Mm-hmm.
course, political leadership, very bipartisan, fragmented messages in US has really harmed. And then came the election, and also lots of rallying and social, turmoil has also had a major role to play. But right now in US, it is really spreading like wildfire, and I'm really concerned about that,
Mm.
because and another thing which is very different between the two countries is the rate of fatalities. And so US has had a much higher case fatality ratio and an infection fatality rate. So
Why is that? Is that biological or like a certain strain of the virus, or is it the hospital response system, or they're
yes, so
catching it late? They're ignoring it and catching it late. By that time, the likelihood of getting more mortality, morbid patients are higher. Any sense there?
so I think again probably a composition of many different things. So
Okay.
India definitely has a younger population, right?
Mhm.
So, but that does not explain the age pyramid structure being different in the two
Exactly.
countries. And there has been several paper by economists and demographers does not explain the difference in mortality rates. I think the comorbidities and the older population is definitely an issue. But also with the winter coming, I think
I
that
see.
in cold areas, people gathering together in closed spaces, India has a much more open air, right? Air conditioning is less common. People's lifestyle of being outside is important. Cross immunity,
Mm-hmm.
being exposed to so many different infections and
Mm-hmm.
vaccinations as well. Genetics could have a role to play. We do not completely understand.
Mm.
But even if I take the death underreporting, another thing which I think is different between the two countries, there is a degree of underreporting in terms of deaths in US as well,
Mm.
because you cannot always attribute the cause of death to
Mm.
coronavirus.
Mm.
But I feel in India it has been really, really rampant, because I know of many cases where there was a death post COVID due to
Rep-
post COVID complication. It is never really registered as
Tagged
a
as,
COVID
yeah.
related death. It's heart failure or kidney disease. So you're missing a lot of deaths on that account. And
Yeah.
1 out of 5 deaths in India normally are medically reported. And then you have that. So I
Yeah.
think that it is really important to create a cohort of COVID survivors
Mm-hmm.
to understand what is the rate of death going
Mm-hmm.
forward, right,
Mm-hmm.
as a cohort. Is there any excess death? And we can compare it to the population and see that what is the real impact of COVID over a time period.
Yeah, the BBC just wrote an article, Sotik Biswas wrote an article covering these two Kerala gentlemen who every day were coding from the obituaries in the Malayali newspapers, deaths, and they showed like I think it's 3,300 deaths in Kerala. As per their calculations, but the officially reported deaths is 1,900 odd, and that practice of like using unusual sources to track what has happened to deaths and then reconciling it with the official numbers, I think will bring the reality closer to the one reported. And you're absolutely right there. One small little thing that I wanted to bring up here was when you're talking about deaths reporting and testing, and how we should look as citizens to the government. Of course, we have a role, we have a third role, which is we are the scientists in this troika. We are supposed to inform and hopefully impact policy making. Um, Transparency seems to be a big issue, right? The big theme is that transparency is a big issue, and it was the standards were set. Some of the big puzzles as to why pricing is different, why death rates are different, are there, and we will probably solve it as a scientific community. But transparency standards were set with the Hopkins dashboard in the beginning of the coronavirus pandemic. It was not there in a China. India has immediately latched onto a dashboard. Yes, it might, one can argue that it's not perfect and stuff like that. And how do we carry forward that spirit of transparency and data to the vaccine situation? Because one can be less assured that whether it's the Oxford vaccine or Gamalaya vaccine or the domestically done vaccines, there would be adverse events. How does the government manage that data, share that data, and accordingly create a response around that data is something I'm very curious to learn about. Any reactions there?
Yeah, that's an excellent question because we really need, like, we have to gather safety data on the
Mm,
vaccine long, long after it has been released and rolled out because
yeah.
some are short-term acute effects and some are long-term effects, and we really, really need to know. So, I think that again, in Europe, there is an advantage of having the national health system or
Right.
an universal, like connected electronic health record, so that every time you seek a healthcare, and be it distributed through the government or private, you scan this ID. So
Uh-huh.
I think a few months ago, I heard that there is a effort like that in
Yeah.
India to give everybody a health ID so
Yeah.
that you can digitally connected regardless of
Yeah.
where you go to seek your healthcare.
Yeah.
So that's the only way, because even in a country like United States, without a connected, universally connected electronic health records,
Yeah.
it will not be clear. Maybe I get the vaccine in Michigan, but then I know all my health effects happen in a
Mm-hmm.
hospital, are recorded in a hospital in California. And
Mm-hmm.
so I will never be able to map this to my vaccination record if I don't have a national registry for it, or I do not have a digitally connected system. So I think this is incredibly important for India, not just to track health effects, but also to distribute the vaccines,
Yeah.
right? Who have, how many people are at risk of high risk of heart disease? How many people are immune compromised? Right now, we do not have any idea. And we
Yeah.
may have that idea in some urban metros, in some particular hospitals. But what happens in rural areas? How can we tap into ASHA workers and community health workers to understand what is happening in a village? So it has to be a ground up process of building this network, of really understanding the health map of the country. And I think that India has been a data deficient environment for a long, long
Long
time.
time.
We just cannot afford it. We just cannot afford it. As you mentioned, that we have to learn from this experience. This is not the last epidemic or a
Yep.
pandemic that we are seeing. We have to be positioned in order to combat the future. And this universal health ID for everyone, just like the Aadhaar card, I think is extremely important for India to roll out.
Yeah, and there are spillovers to other positive ways through which this kind of a system can help in healthcare policy interventions. Though that being said, I do want to highlight as well that the government, previous or the new one, hasn't done a great job in generating trust around privacy issues and security issues, whether it's the Aadhaar card or I mean, I guess this is how India operates. Part of it is thumping down from the top, and our rest of it is somewhat adoption, and then we roll on and make things quasi legitimate. So we'll see how Arogya Setu, for example. I mean, the app has been there. So many folks have downloaded it. I see my like these vendors who are delivering over Zomato, registering their temperatures. I wish government had actually socialized that data, just like the safe graph data has been socialized to track mobility patterns in the US. I would love to see Zomato or Arogya Setu and all these kinds of data environment that is there socialized so that people get confidence in the digital environment in sharing their data. Else it will become a little bit like of authoritarian tendencies could come in the way technology will be adopted. Um,
Absolutely. Like, you have to, just like in every economic product, you have to sell your product to the public. And if the public saw that by using this data and say the mobility pattern data,
yeah,
you are saving lives.
yeah,
For example, in South Korea, they have such level of information, including where you are swiping your credit card. But when the public actually sees that with that, we have single digit case
yeah,
counts,
yeah.
then you say, yes, I'm going to
I
do
will
it.
share my data. Yeah,
Yeah, some
absolutely.
fragment of the population still may not, but a large fragment of the population will do it. So the use of this data, and data is the new coinage, and actually really, really to show and demonstrate to people what scientists can do with data. India has such a advanced like machine learning, AI, computational infrastructure to get all of this, harness that untapped sources and give them this data and build really thoughtful, granular level models. I think it's going to be, then people will buy in. You need that buy in and the trust in order to roll out these ideas, which are all have a very good, kernel of a very potential of really be game changing, but you have to show, instead of proprietarily holding the data and nobody understands how you're using it, you really have to demonstrate that through science.
Mm. And in that way, the virus may suddenly change the normal in the way we have been dealing with data over the last decade or something like that. So let's hope for the best.
So I think
Maybe,
that would be a good outcome of the pandemic if there is a
yeah,
complete overhaul of
yeah.
India's health data infrastructure.
Yeah, yeah, absolutely. Fully agree with you. I hope people are listening everywhere and making those changes that they have to make. Maybe this is a good time. We are almost close to the like the last section of our chat. It's a good time to document what are the learnings from this pandemic for tomorrow, for the world, and maybe from, let's say, these two settings that we are talking about, us from us for India and from India for us. Any listing of thoughts and puzzles to look after, from where we can be better prepared for tomorrow's pandemics, because pandemics are coming. I mean, there's no way this is going away. New versions of this will come. We know that Bill Gates has been talking about it for some time now. Broad lessons as society.
Yeah. So I'd like to throw a new spin to this, that we need to understand both prevention and treatment.
Hmm.
So prevention is often very hard to invest in.
Hmm.
If a country like India or US had a really active and thoughtful pandemic response team,
Hmm.
that the maintenance of this team is probably going to cost about say $1 billion in a decade. But when you have, and people cannot immediately see the advantage
Benefits.
of having that preventive measures and preparedness, because it's not happening. So we are really wasting money. But it's just like, even if wars happen once in a lifetime, you
Yeah,
still have your army prepared all the time. And
yeah.
so that's true for healthcare as well. And prevention is hard. We don't want to change our behavior. We don't want to stop smoking. We don't want to exercise. We don't want to change our diets. We want the physicians to fix it, right?
Hmm.
So there is an overemphasis in all the cultures on treatment
Hmm.
rather than modifying your behavior in
Hmm.
towards a healthier and better world. So but medicine is really a composition and union of both public health and healthcare. So I
Right.
think that message of prevention, and right now we are trying to prevent and slow down the virus so that the healthcare capacity does not get overwhelmed. One thing which has been common and inspiring in both the countries is the effort by our healthcare workers.
Yeah, yeah,
So inspiring, and we have seen so many heroes who just
yeah.
want to make people get people better. And so if you look at that spectrum, I think that there is a lot of respect for healthcare heroes, but we have to have really value placed on prevention and public health. And data is a very much a part of both prevention and treatment, as we are seeing with clinical trials, with vaccine distribution. We have to how to deploy PPEs and resources, not just epidemiologic models to predict case counts, but also use it at a resource allocation level because we have finite resources. So I think to be nimble and agile with data takes you a long way in today's world. And
Hmm.
I think that both the countries have to learn from that. And then, political agenda and partisan politics should really take a back seat when it's a question of survival for humanity. And I
Hmm.
think that we both the countries probably have a long way to go. The third thing I think that we have really not focused on the mental health or the
Yeah,
humanitarian aspect of it. We have just gone on science, 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 but really
the
it comes
healing part. Yeah.
it's a really social chaos right now, and everybody is suffering. To take that aspect of the human tragedy and to really place value on hope, optimism, this is really, really important. These are intangible things. These are not medicine for the body, but you need medicine for the mind as well. And I think we have underplayed that. And that is something to learn in both the countries in times of isolation, what social support, social cohesion, family, all of these things mean to us. Another thing is this the disparity, right? The distribution of loss. From
Yeah,
Detroit, Michigan to Dharavi, Mumbai has not been equal. There are structural inequities in our society that we must address in order to have a healthier, more equitable world.
excellent point. So just to summarize, we need to invest in long-term preventive programs in the vein of what, let's say, US already had, but then it, I think, disbanded the pandemic response preparedness teams. Second, we need to believe in um, healing ourselves. I mean, it's not just about a scientific response, but also about taking care of our social shocks that we are receiving as in different cultures. The third is understanding the structural inequities that you mentioned from Detroit to Dharavi. Very well said. Am I missing? I think I'm missing one fourth point, which is um, struggling to get it. What was it?
Data, the importance of
Of
data,
data.
right?
Yeah,
So
yeah.
both healthcare and public health. And
Right.
another thing is that, we can't
Political aspects you mentioned. Yeah.
partisan politics. So that's a part of the societal chaos. I also want to mention that once a pandemic like in a 100 year happens, just think about like if we're better prepared, then the cost of maintenance is actually much less than all of these economic stimulus packages that are being given out right now. If you think about the trillions of dollars that are
Yeah.
going out, it is
Yeah.
much easier to maintain a pandemic response team for $1 billion investment over time. So that perspective, that wiser and long-term
Mm,
perspective has to be gained by all of us.
awesome. Any last thoughts from your side for our viewers?
I think as much as I have done my modeling and relied on quantitative work, I have found a lot of solace and inspiration from reading about history and also poetry, literature, art in the time of such crisis for humanity.
Yeah.
During big wars, during pandemic, during the 1918 influenza pandemic. And this has been inspiring that, this is not new, and I'd like to conclude with Rilke's poem that let everything happen to you, the beauty and the terror, just keep going. No feeling is final.
Thank you so much. I also love Rilke. Thank you so much for your time, and we really appreciate taking out this schedule for us for our from your busy class schedules. I know you're juggling time zones between Michigan and Kolkata, so thank you very much. Wish you safe year-ending wishes, and hopefully we'll be able to host you in campus once these things subside. Thank you very much again, Professor
Thank you,
Mukherjee.
Shirantan. And one of the best parts of modeling and getting involved in this work has been my connection with the scientists in India. And so I found a new community of friends here. And after all of the science and all world all said and done, it's friends that matter the most. So
Indeed.
yes, so thank you very much.
Thank you. I'm going to stop recording.